Welcome to Samaritans Purse International Health Forum. Thank you for joining us today. We hope that you're able to participate in our conversation today. Just want to remind you that you can chat with us in the sidebar of the chat box beside the video. So before we begin our presentation and I introduce our speaker to you today, I just want to open us up in prayer. So if you'll pray with me. Father God, thank you for the opportunity to come and to learn. Thank you for Dr. Mabula and her heart to share with us today. Lord, bless her talk, bless our conversation, and we just give you this time. In your name we pray. Amen.
Amen.
Today I am excited to introduce Dr. Linda Mabula to you. She will be talking to us on post-Ebola syndrome, post-viral sequelae among survivors of Ebola virus disease. There's no one better to talk to us, I think, on this topic. To introduce Dr. Mabula, she holds a BS in biochemistry and molecular biophysics from the University of Arizona. She's an MD from UCSF, with a concentration in global health. She holds an MPH from Johns Hopkins Bloomberg School of Public Health with a concentration in health in crisis and humanitarian emergencies. She currently serves as a public health and infectious disease advisor with OFDA at the United States Agency for International Development. She's also on faculty at the Department of Medicine at Johns Hopkins University, and she's the co-principal investigator of Ghana Access and Affordability Program. Dr. Mabula has extensive prior experience, including the Office of HIV and AIDS at USAID, where she provided technical assistance to countries such as South Sudan, DRC, Mozambique, and Burundi. She has been the medical director for Samaritans Purse health programs in Haiti. She's been the chief medical officer for Samaritans Purse response to the typhoon in the Philippines. She served as SP's Ebola response in Liberia during the summer of 2014. She's been a health advisor and deputy DART team leader for USAID, OFDA, Ebola response in Guinea, and she's been acting senior humanitarian advisor for OFDA in Guinea and the senior program manager for Samaritans Purse European refugee response in Greece. So as you can see, Dr. Mabula has quite an extensive list of experience and education. We're excited that she is coming to speak to us today. So without any further ado, Dr. Mabula, if you would go ahead and start your presentation.
Thank you, Beth. Hello, everybody. Thanks for joining the talk. So as Beth mentioned, the title of the talk is Post-Ebola virus disease syndrome. We're going to talk about some of the symptoms that are part of Ebola syndrome, Ebola virus syndrome among survivors. Next slide, please. I have no disclosures to report. Next slide. I'm going to start by giving a brief overview of what Ebola virus disease is. Ebola virus disease was formerly known as Ebola hemorrhagic fever, and it's caused by Ebola virus, and it's part of the filovirus family, which includes other viruses such as Marburg virus. Ebola virus disease causes an acute illness, case fatality rates, and causes severe morbidity. When patients present, they initially present with symptoms that are very similar to malaria. So fever, diarrhea, nausea, vomiting, headaches. So the disease itself was actually identified in the Democratic Republic of the Congo in 1976. Identified after a Belgian nun died, and there was an investigation that ensued. And it turned out that there were two simultaneous outbreaks in both DRC and South Sudan in 1976. Next slide, please. So this map actually shows you various outbreaks that occurred prior to the outbreak in West Africa. So historically, most of the outbreaks occurred in Central and Eastern Africa. As I mentioned, the first two outbreaks occurred in 1976 in DRC and in the Sudan. There were subsequent outbreaks in Uganda, the Republic of the Congo, Gabon, and Ivory Coast. Note that these outbreaks were smaller in scale and had very few people that were actually infected by Ebola. The number of survivors was also very limited. So what we know about Ebola survivors was limited and was based on outbreaks that occurred previously. One of the largest outbreaks previously had been in a town called Kikwit in the DRC. And that outbreak occurred in 1995. And a lot of what's been published so far on Ebola survivors comes from that outbreak. Next slide, please. So why was the West Africa Ebola outbreak significant? First of all, it was unprecedented because of the geographic scope. So for the first time, you actually had an outbreak that spanned multiple countries, including Guinea, Sierra Leone, Liberia. There were cases in Mali, in Nigeria, but also cases in the United States. And the duration of the outbreak went from December 2013, where you had your index case, all the way to June 2016. So the last cluster of Ebola cases occurred in Guinea. Affected. There were more than 20,000 people that were diagnosed that with Ebola were either confirmed, suspect, or probable cases. And there were more than 10,000 deaths. But also it's estimated that there are more than 17,000 survivors, which is the largest cohort of survivors to ever exist. Next slide, please. What is post-Ebola syndrome? So it's a constellation of symptoms that are reported by survivors, and we characterize it as post-Ebola virus syndrome. And it actually causes a variety of symptoms, including auditory, ocular, and arthritic symptoms. And these symptoms have been described in previous outbreaks. Additional symptoms include fatigue, headache, visual disturbances, short memory impairment. And we're continuing to learn more and more about some of the symptoms that survivors actually are experiencing. Next slide, please. This is a picture of multiple survivors that I've encountered. You probably know the one in the bottom right the most, Kemp Brantley. Other survivors that I've met and interacted with include Ian Crozier, which is on the top, in the picture in the top left. And I'll talk a little bit more about his case in particular. He's been an advocate, as Kent has been, for the Ebola outbreak in West Africa, but also really trying to focus on advocating for survivors. The top right picture was taken in Guinea with a group of survivors in November 2014. And at that time, there was very little that was being done for survivors necessarily. So we held a group of focus group discussions with survivors, trying to understand what their needs were, both from a clinical standpoint, but also socioeconomic. I held another focus group discussion with survivors later on in May 2015. Picture in the bottom left, and I'll talk a little bit more about some of the outcome of these discussions. Next slide, please. As I mentioned, this was the first time that you had a large group of survivors, 17,000 survivors. And as a result, there's a lot of new data that's been collected on survivors and a lot of information about some of their needs. This large cohort of survivors has raised several questions on clinical care, including the need for subspecialty care for complications that survivors are facing. And given the fact that we're dealing with low-income, low-resource areas, how do you really ensure that survivors have access to subspecialty care when primary health care is very challenging in itself? There are a lot of psychosocial related issues, depression, but also stigma. And how do you ensure that survivors have access to the appropriate support? There was a case where, previous slide, please. Recently, there was a case where there was reactivation of the virus in a woman who had contracted Ebola in Sierra Leone, about what the implications of reactivation are with regards to transmission. Are things that have resurgence due to sexual transmission is another very important topic. And we'll discuss all of these in my presentation. Next slide, please. So I'm going to talk a little bit about the outbreak in Kikwit that I mentioned. Kikwit occurred in 1995, and there were only 315 cases. And I say only with a grain of salt because at that time, that was actually one of the largest outbreak that had occurred in 1995. 244 deaths, so about 100 survivors approximately. What we know came from that outbreak. And there were two small cohorts of survivors that provided data on post-Ebola syndrome. There was a study conducted by Alexander Rowe from the Centers of Disease Control. And he looked at he conducted a prospective study investigating whether or not convalescent body fluids contained Ebola and if there was secondary transmission to Ebola. A group of 29 Ebola survivors and contacts and monitor them for a period of 21 months. And he was able to identify the following sequelae: arthralgia, myalgia, abdominal pain, fatigue, anorexia, and late ocular complications. And this was really the first time it was characterized. Next slide, please. And this is a table that comes from his study, in which he basically outlined some of the symptoms that I described: arthralgias, myalgias, abdominal pain, fatigue, anorexia. And the percentage of patients that had arthralgias was 48%. And he compared that to a group of household contacts and found that patients that were convalescing from Ebola or Ebola survivors were 23 times more likely to develop arthralgias compared to their household contacts. Myalgias was another symptom. Ebola survivors were 6 times more likely to develop myalgias. Abdominal pain, anorexia were also found to be about 3 times more likely, had an odds ratio of 3 compared to household contacts. Next slide, please. There's another paper that was published looking at late manifestations of Ebola survivors, and this cohort was actually a little bit smaller, had 19 survivors from the same outbreak in Kikwiti 1995. And same symptoms were found: arthralgia, ocular disease. Primarily, there was 1 case of uveitis, 1 case of conjunctivitis, and 1 case in which the survivor lost their vision in 1 eye. Other symptoms included hearing loss. There was a diagnosis of orchitis that was made, as well as parotitis. And there's 1 clinically suspected case of pericarditis. And these survivors were only observed for a minimum of 2 weeks and a maximum of 2 months after hospitalization, so not very long. Next slide, please. And overall, survivors basically implied that their general health was so 70% versus 17.9% in household contacts. Their capacity to work was worse, but there's no significant association between a convalescent, a survivor, and a contact regarding hearing loss. Next slide, please. Additional data showed that survivors reported having arthralgias at least once a week during the month preceding the interview, but also arthralgias was the most common symptom found in these survivors. And it's important to make the distinction between rheumatologic causes of joint pain compared versus post-Ebola syndrome, and how that affects your joints. And regarding joint pain in particular, survivors rarely reported that they had painful joints that were either red or swollen. Arthralgias were usually worse in the morning after working. All joint involvement was symmetric, but also the majority of joints involved the knee, back, hips, fingers, wrists, neck, shoulders, ankle. But it's also really important to note that antibody titers were higher in Ebola survivors who reported joint pain compared to those that did not have arthralgias. Next slide, please. So there was a paper that was written, published last year, and it was published on the Bundibugyo Ebola virus, which is a different strain of Ebola. So the strain of Ebola that affected West Africa was the Zaire virus. The Bundibugyo Ebola virus really affected, was the cause of an outbreak in Uganda. And there was a retrospective cohort study that was conducted among 70 survivors after 29 months of the outbreak actually occurring. And very similar symptoms were noted with Ebola Zaire. Include ocular deficits, hearing loss, difficulty swallowing, difficulty sleeping, arthralgias, chronic health problems, and as well as memory. Very similar among survivors that were actually affected by a different strain of Ebola. Next slide, please. And this is a really interesting article that recently was published looking at a cross-sectional study of Ebola survivors from Sierra Leone. And in this study, not only did they list the symptoms that Ebola survivors were experiencing, but they also looked at predictors. So they looked at this cohort of survivors from March 7th, 2015 to April 24th, 2015. Or that's when they recruited the patients. And among 277 survivors, they found that articular complaints were composed the majority of complaints. So 75% actually complained of joint problems. 60% complained of ocular problems, and uveitis was actually diagnosed in 18% of all these patients. Hearing loss or auditory problems was diagnosed among 24% of cases. But they also looked at different factors or predictors that would actually lead to the manifestation of certain symptoms. A significant association or predictor was that of having a higher viral load when you had acute onset of Ebola. And they found that among patients that had a higher viral load, they were 3 times more likely to present with uveitis or with new ocular symptoms or an ocular diagnosis. Next slide, please. So this table comes from this study, and they looked at different factors such as age, male versus female, gender, presenting symptoms at the time of onset of Ebola. So diarrhea, red eyes. Cycle threshold is basically a measure of viral load. So the higher your cycle threshold is, your CT value is, the lower your viral load is. They also looked at duration of acute Ebola in a matter of days. And the only 2 significant predictors were, number 1, viral load, so your CT threshold, as I mentioned, is 3 times more likely. A high viral load, you're 3 times more likely to develop uveitis as opposed to having a lower viral load at time of presentation. So age, gender, self-reported symptoms such as diarrhea and red eyes were not really associated with the development of complications. Next slide, please. As I mentioned before, as shown in previous studies, joint and muscle pain are the most common symptoms seen in the Ebola patients. And the way patients present with joint and muscle pain is very similar to complications related to hepatitis B, parvovirus, and rubella. And it's not clear what the etiology of the joint and muscle pain is, but some of the so it's suggested that these arthropathies result from either viral replication in the joint or deposition of immune complexes in joint tissue. The course of arthralgias is very similar to that of other viral pathogens such as hepatitis B, parvovirus, and rubella. So the treatment is conservative management, including bed rest and treatment with NSAIDs. Okay, next slide. I talked about hearing loss as well. The prevalence of hearing loss is unknown in post-Ebola virus disease syndrome. It's interesting because hearing loss was also reported in Lassa fever, which is another viral hemorrhagic fever. And in Bundibugyo, the risk of hearing loss was twice as likely in Ebola survivors compared to control. And 50% of patients in a study that was conducted in 2005 reported moderate hearing loss. It's interesting that in Kikwi, there was no significant hearing loss reported, and that could have just been due to the fact that the cohort was a lot smaller. So there's still a lot of work that needs to be done as it relates to hearing loss in post-Ebola syndrome. Next slide, please. So ocular manifestations is another complication, and the pathophysiology of ocular manifestations in post-Ebola virus syndrome is unclear. And you have both early and late manifestations. In the early phase, you typically have conjunctivitis or subconjunctival hemorrhage, lacrimation. Some of the late ocular manifestations include uveitis, and you can have panuveitis in different chambers, cataract disease, as well as optic nerve disease. Next slide. As mentioned, the pathophysiology of Ebola-associated uveitis is unknown. The way it manifests is typically with an acute onset of symptoms, unilateral location. You have increased elevation and intraocular pressure. And again, these findings are very similar to infectious uveitis syndromes caused by other viruses such as herpes. Marburg virus has also been associated with uveitis, similar to Ebola. And it's interesting because typically you actually see a high burden of viable Ebola Zaire virus when ocular symptoms present in patients, but further studies are warranted to really characterize the pathophysiology of Ebola-associated uveitis. Next slide, please. So I'm going to do a case study. I talked about Ian Crozier. As I mentioned Ian Crozier earlier on in the presentation. He's an Ebola survivor who contracted Ebola in Sierra Leone in September 2014. His case of Ebola was a lot more severe than most cases. He developed multi-organ failure, requiring mechanical ventilation for 12 days, and was on dialysis for 24 days. And he was discharged home, and 14 weeks after his discharge, he presented with an acute onset of blurred vision in one eye. He had photophobia, redness, blurred vision with halos. He was transferred to Emory Hospital and was found to have severe panuveitis that affected the anterior, intermediate, and posterior chamber of his eye. At Emory, they were able to isolate viable Ebola virus in his aqueous humor 14 weeks after the onset of Ebola. And after 9 weeks, he was actually cleared. So it's 14 weeks after the onset of Ebola and 9 weeks after the clearance of his viremia. His blood cultures were found to be negative. And you might recognize this picture that was from the New York Times. It was actually also published in the New England Journal of Medicine. So his eye turned, so when he developed acute onset of these symptoms, his eye turned green. He has blue eyes, and his eye literally turned green. And it's not clear what the pathophysiology again is. And there's still a lot of work that needs to be done related to uveitis associated with Ebola virus disease. Next slide, please. So another really interesting topic has to do with viral persistence of Ebola virus in various body fluids. And I'm going to talk a little bit about sexual transmission of Ebola virus. So prior reports from both Ebola and Marburg indicated that filoviruses, which is a family in which Ebola is part of, so filoviruses may be sexually transmitted by male survivors, and seminal fluid may contain RNA from Ebola or infectious particles. And it's interesting because for the longest time, there were public health messages indicating that Ebola would persist 3 months. And however, with recent studies, it's been shown that Ebola virus persists a lot longer. So the evidence we had prior to West Africa indicated that Ebola virus would persist in semen and cell culture for a maximum duration of 82 days after disease onset. And it could be detected via PCR for a maximum of 101 days after disease onset. And what we've learned from this recent outbreak has shown us that it actually persists beyond 2 years now. A little bit more about that. Next slide. So the first, I guess, evidence that started coming out regarding sexual transmission or potential for sexual transmission came from Liberia. So 30 days after Liberia was declared Ebola free, a 44-year-old woman was found to have Ebola virus disease. And they were able to demonstrate that there was molecular evidence of human-to-human sexual transmission from this woman who had intercourse with a man who was a survivor, and he had been diagnosed 199 days prior to her diagnosis. And this was the first time there was actually molecular evidence of sexual transmission of Ebola. It had been suggested that it was possible in prior outbreaks, but this is the first time we actually had molecular evidence. Next slide, please. And this slide here shows It's basically this tree looking at resurgence of Ebola virus disease in Guinea. So about a year ago, on March 31st, ready to declare itself Ebola free after 90 days of heightened surveillance as mandated by WHO. And I was in Guinea at the time. And there were reports of a young girl who was part of a family that had 3 deaths back to back, so separated by about 2 weeks. So there was a lot of concern, obviously, given the pattern of death and given the cluster of deaths. This young girl was tested. She was found to be positive, and it turns out that there was an Ebola survivor who transmitted Ebola to a woman in that village. And this was 531 days after he recovered, so a little bit more than 2 years. A lot of shock, because initially, we thought Ebola persisted in semen for 3 months, so 90 days. And the more evidence we got while observing, different cohorts of Ebola survivors demonstrated that it actually persists beyond 2 years. And the question was, what's the risk of transmission if you have Ebola in your semen? And it turns out that based on molecular studies, that Ebola survivors can still be infectious after 2 years if there is Ebola present in their semen. Next slide, please. And this slide, this table or graph comes from the study in Sierra Leone that I had mentioned previously. And it looks at the proportion of male survivors that still have Ebola RNA in their seminal fluid. So what actually, that's when you have the highest proportion of cohorts that have Ebola in their seminal fluid. And as time goes by, so after 450 days, the proportion of individuals that have Ebola in their seminal fluids decreases quite rapidly. So this is really the first time we've been able to do longitudinal studies looking at the presence of Ebola in different body fluids. And the only reason we're able to do this is because of the high number of survivors, but also because of the amount of resources that have been dedicated to studying Ebola survivors. Next slide, please. And there are a lot of different questions about Ebola survivors that that are unknown. For example, we don't know what happens to a woman survivor once she becomes pregnant after she recovers. There's no evidence that women who became pregnant after recovering from Ebola had persistent virus in their placenta. There wasn't any evidence that women could actually transmit Ebola to their child after recovery. Ebola virus RNA has been detected at low levels in breast milk for up to 16 months after onset of symptoms. And that's something that needs to be studied further because of the risk of transmission from mother to child during breastfeeding. There have been numerous reports of stillbirths that have occurred in men who have conceived after recovering from Ebola. Whether or not those rates are actually higher than in the general population. Are those stillbirths attributed to Ebola, or are they because of other reasons? It's not very clear. Next slide, please. And this case was actually very interesting. So Pauline Cafferkey is a Scottish nurse who contracted Ebola in Sierra Leone in December 2014. And she was transferred to the UK and treated in the UK. So 9 months after she got discharged, she was readmitted to the hospital in Glasgow where she was initially treated to have meningitis that was caused by Ebola. So both her CSF and her plasma tested positive for Ebola 10 months after her initial diagnosis. And this raised a lot of questions about relapse, but also about whether or not Ebola survivors can actually still transmit Ebola. So the amount of Ebola that was found in her plasma was a lot less than that in her CSF. However, there were a lot of questions about healthcare staff that were treating her. Should they be wearing PPE? Could she actually have Ebola again? Because the theory so far has been once you recover from Ebola, you can never get it again because you have antibodies. But this case really tested that theory and basically demonstrated that you can have a relapse of Ebola among survivors. And so there are a lot of different studies that need to be done to characterize this. I think one of the challenges, though, especially in West Africa, is if you have really severe disease, you typically die because you don't have the same quality of care in West Africa. So this might have happened before relapses of Ebola among survivors, or you could have had survivors that got reinfected, but they potentially could have either died or they weren't monitored. So it's not very clear whether or not this has happened in Africa as well. But the fact of the matter is that late severe relapses of Ebola virus can occur. And in this case, it occurred in the CNS. It so happens that Pauline Cafferkey had a really high viral load as well. So, the question is, do high viral loads lead to relapse? Do high viral loads lead to increased incidence of symptoms related to post-Ebola syndrome? And there seems to be that association of really severe disease with the incidence of severe post-Ebola virus disease syndrome. Next slide, please. So in conclusion, as I mentioned, severe disease, which generally correlates with high levels of viremia, might lead to viral persistence in certain body fluids and long-term complications, including uveitis, meningitis, as demonstrated by Pauline Cafferkey's case. And there's a lot of research that needs to be done to understand the pathogenesis of these complications and how do you optimize treatment? How do you treat these patients? Do you just use standard of care for meningitis, for arthralgias, or is there a different therapy that's needed? We're not exactly sure. However, WHO has produced interim guidance on the care for Ebola survivors, and Ian Crozier was actually part of that. He ended up joining the World Health Organization and he helped contribute to the literature in building basically this manuscript or guidelines to treat Ebola survivors. And so in view of the large number of Ebola survivors in West Africa and the potential to relapse and to initiate new transmission, so these are really serious public health concerns. And there are a lot of questions about why the West Africa outbreak in particular was so large in terms of its scope. And it's possible there could have been relapse and sexual transmission that occurred during this outbreak, and that's the reason why you had continued transmission. It's unclear whether to what extent sexual transmission contributed to this outbreak, surging. We do know, based on a study in Guinea, that unsafe burials contributed to 60% of transmission, specifically in Guinea. It's unclear whether or not there was relapse that occurred, or viral persistence in certain body fluids, and whether that contributed to the continuation of the ongoing transmission of this virus. There are a lot of questions about reproductive health in women of childbearing age. As I mentioned, we don't know what happens once a woman of childbearing age recovers and becomes pregnant. So far, there's no evidence that she can still transmit Ebola to her child, because there's no evidence that there's actually Ebola in amniotic fluid or in her placenta. But further studies need to be done. Another big unknown is what the long-term effect, cognitive and neurologic function is in children. So if a child recovers from Ebola, we don't know long-term what's going to happen to that child as they get older. And there are several cohorts that have been established in Liberia, Guinea, and Sierra Leone, where these patients will be followed for several years. The PREVAIL study that's being done in Liberia, that's being funded by the National Institutes for Health, plans on monitoring patients for several years. And as the years go by, we'll get more and more information about what happens to Ebola survivors. I think that's all I have. And let me know if there are any questions.
Thank you so much, Dr. Linda. That was a fabulous presentation and really good information. And I think there's a a lot of questions, like you said, that still need to be answered. There's a lot of research that still needs to be done, and but just very fascinating. I want to remind our guests that are participating today that if you have questions for Dr. Linda, if you would put them in the chat box beside the video, we will see those, and that is how you can communicate with us. Just a quick question to kind of start it off. Would you say that every Ebola survivor has some sort of post-Ebola complication? Is there really anyone who just goes through the course of disease and ends up with, you know, no residual effect, or is it everybody has something?
It's hard to say. I think there's a big range. There are, you know, early and late complications. There are patients that recover and who do well and who don't have any complications. Ken Brantley is one of them. And there are patients that have several complications. And I think because of the range of symptoms you can develop, because the range is so wide, it's possible that people have symptoms and they don't think it's related to Ebola necessarily. It's just headaches, memory problems, fatigue. So yes, I would say yes, it's possible that there are Ebola survivors that don't have any complications. But I think one common symptom or effect of Ebola that you see kind of across the board is stigma, unfortunately. And that can create either depression, anxiety, or other psychosocial issues. But again, you know, the range is very wide. There are people that don't have any complications, and there are people that do. And I think it's really related to viral load and how high your viremia was when you actually got sick.
Mm-hmm. So less to do with age or other even complicating conditions maybe before you got the disease, but more to do with just viral load would be the takeaway.
You know, yeah, but I also think that once we get data published or data from like the PREVAIL trial, for example, they actually looked at cohorts of patients that were HIV positive and HIV negative. Mm-hmm. And it'll be interesting to see whether, you know, the presence of, you know, an immunodeficiency like HIV led to increased symptoms. The information yet, and as this data starts getting published, we'll have more information on whether or not comorbidities like diabetes, heart disease actually lead to an increased incidence of post-Ebola disease.
Sure. Well, thank you so much, Dr. Mabula, for this great presentation. It looks like our audience is a little bit quiet today, so we don't have a ton of questions, but I think you've done just a fabulous job explaining this to us, and I want to thank you for your time today. Also want to remind our viewers, if you would like to receive CME for this presentation, to please follow the instructions in your email. You should have the evaluation form there, and it tells you where to send it and how to get credit for this presentation. If you are not on the email list, you can join us to get the latest updates at health.samaritanspurse.org, and you can know about our upcoming events, and that will also give you the links and such things to get the CME credit. Our next webinar is scheduled for June 21st. It's a Wednesday. It will be by Dr. Joel Jackson, and he will be talking about trauma surgery in a war-torn context, experiences from a tent hospital. It will be something you will not want to miss. It does look like there is one question that just came in, so before I conclude the presentation, I will ask that to you, Dr. Mabula. This is from Bruce. He said, patients may essentially be asymptomatic after Ebola, but virus and blood may be a risk to the healthcare providers, especially surgeons. Should post-Ebola folks be tested prior to procedures?
That's a good question. I think so far, if you're not symptomatic, you're not infectious. I mean, that's been demonstrated. So there haven't been any policies on that Ebola survivors should be tested prior to a procedure. But I think if a patient is symptomatic, they definitely should be tested for Ebola. But if they're asymptomatic and there's no kind of the risk of actually, if you don't think that they actually have Ebola, I would say there's no need to test them. However, I don't think there have been guidelines that have been developed to that effect. There have been patients that have been asymptomatic, while they actually, and they ended up being positive. They had a positive IgM, and IgG were completely asymptomatic, and it's not clear whether or not they are infectious. But I think that needs to be studied a little bit more, and I wonder if one study that can be conducted is just looking at Ebola survivors and looking at whether or not their RT-PCR is positive or negative, or if they have a little bit of viremia. Procedures, because that information really is not available. So that's a study that can be conducted and will then inform further policies on whether to test survivors prior to a procedure.
Mm-hmm. That's great. Another question from Karen, Linda, is I know you know her and you guys work together, and she is asking that you were never really able to know the viral load off your patients in FOIA, rather just that they were positive or negative. How did they discern this in the patients that are now being followed, the viral load?
Sure. So back in, so during the summer 2014, there was a lab in Monrovia where we sent all of our samples, and the lab basically reported whether or not the patient was positive or negative, as Karen mentioned. But now every lab that reports on viral load is actually obligated to also provide a cycle threshold, which is an indication of viral load. So viral loads that are high have a low cycle threshold, and vice versa. So every lab is now obligated to provide cycle threshold, so CT values for every patient that's positive. It's really important because it basically provides a limit for detection of the virus and determines how sick your patient is. It provides you kind of an estimation of their viremia. That's a really good question, Karen, because I think 3 years ago, we were just told whether a patient was positive or negative, but now it's actually required for every lab to determine what the CT value is.
Great. Well, thank you again, Dr. Mabula. Again, we just appreciate your time today, and this was a great conversation, and thank you to all of you who participated today and listening to this, and we hope you'll join us again next month.
Thank you. Goodbye.
All right. Goodbye.